How's it going, everyone? Today we are going to be discussing the heart. And the heart is a major organ in our body because it beats every single second to supply blood to the rest of the body. And we're going to talk more about blood and everything that it does and everything that it carries in later chapters. But just know that blood flow is critical for survival, and it carries the oxygen, it carries nutrients, it carries hormones, it carries wastes. And so we need something to generate enough force and enough pressure to transport that blood throughout the body. And so the organ that does that in our case is the heart, and we'll be learning all about how it does that today. Blood flow is delivered to the lungs and to the rest of the body in order to exchange certain nutrients or certain chemicals or certain gases. And so we divide this up into the pulmonary circuit, which is where the blood flow to the lungs will occur. And so you see that blood will leave the right side of the heart in order to be transported to the lungs. There we're going to get an exchange of O2 and CO2. CO2 will go from the blood to the lungs and then be exhaled out, and then oxygen will come from the lungs to the blood and then be transported back to the heart and then eventually to the rest of the body. And you can see that in order to transport that blood to the rest of the body, that oxygenated blood dumps into the left side of the heart and then is ejected out the aorta to be delivered to all of the organs and all the tissues and all the cells located in our systemic circulation. We could see that the blood pathways in our body are set up as a parallel circuit. And so what that means is that blood doesn't have to travel in a straight line in order to get to a destination. These blood vessels will break apart and go in separate directions, so there are own, circuits for different organs and different parts of the body. And so, if you needed to get blood to the lower limbs, it doesn't need to go through all of the upper organs before that blood is delivered. And so setting our bodies up in this parallel circuit is advantageous because it also allows us to sort of manipulate blood flow to each area of the body. So let's say if we're in a situation where we needed more blood flow to go to the skeletal muscles, think exercise, well then we are able to deliver more to those muscles and then less to maybe certain parts of the body that don't need as much blood during that time. And so this parallel circuit allows us just again to deliver blood flow to different areas of the body, and we can ultimately change that blood flow based on the activities and the environment that is currently going on. Our heart is located in our chest, in our thoracic cavity, in between our lungs. It's about the size of a fist. And again, it's going to beat every single second to drive up enough pressure and to drive enough force to deliver that blood to the rest of the body. But again, it's just tucked right in here, which makes for easy delivery of blood to the lungs. And then, you're going to see these great vessels coming in and coming out of the heart in order to deliver blood in and in order to deliver blood out. The pericardium is this sac that surrounds the heart and anchors the heart in place. And what we're going to find out about the pericardium is that it is necessary to prevent the cardiac muscles from extending too far out. Remember that the heart is going to contain cardiac muscle fibers, which generate force and allow for blood to be ejected out and be transported to the rest of the body. So the pericardium sort of limits the amount that heart is going to stretch, but that stiffness can be impacted by certain things, such as exercise. And so those who are heavily involved in aerobic activity and endurance activities tend to have a little bit less stiffness in that pericardium, and it allows the heart to actually fill up with a little bit more blood in the ventricles. So the pericardium will help protect the heart, but these other layers of the heart include the epicardium, which is the most outer layer of tissue, which, it's going to surround what's called the myocardium. So these are actually those cardiac muscle fibers, the ones that are going to generate force and produce enough pressure inside of the ventricles to eject blood out. And then we have the endocardium, which lines the inside of the heart and lines all of the chambers of the heart. Speaking of chambers, we have 4 in total. We have 2 atria and 2 ventricles. Blood is going to enter the heart through these atria. And so we see on the right side, deoxygenated blood is going to come from the upper body and the lower body, and that is how we are going to take blood in. And then that blood gets transported to the right ventricle, and then that right ventricle is going to eject that low oxygenated blood to the lungs in order to get oxygen and in order to get rid of CO2. And so that right side of the heart, it serves to supply blood to the pulmonary circuit, or our lungs. And so once that blood comes through and is oxygenized and that CO2 is dumped off, then it returns right back to the heart through the left atria. And then once that blood enters the left atria, it's going to go down into the left ventricle, and the left ventricle is going to eject blood out to the rest of the body, to the systemic circuit. So again, that right side serves the pulmonary circuit, that left side serves the systemic circuit. Blood enters through the atria, and then the ventricles will help to eject blood out. Here we can see another view of those chambers. We can tell again that these atria are going to receive blood through what are called great vessels. And so for venous blood, or deoxygenated blood, and let me just take a second to point out that deoxygenated doesn't mean completely absent of oxygen. It is just blood that has already been transported to an organ or to tissues or to cells, and most of that oxygen has been extracted from the blood in order for the cell to use. And so the venous blood just has significantly less oxygen, hence deoxygenated. But anyway, that venous blood is going to enter through the right atrium. All the venous blood above the heart will enter through what's called the superior vena cava, and all the blood the deoxygenated blood that is below the heart is going to enter through what's called the inferior vena cava. So all that blood, all that deoxygenated, all that venous blood enters through the right atrium. And then on the left side, we are going to have what's called the pulmonary veins. And so this is, when you think about throughout the systemic circulation, arteries go away from the heart, carry arterial blood or oxygenated blood, and then veins go towards the heart, right, and carry deoxygenated venous blood, right? But when you're talking about the pulmonary vessels, it actually switches. So pulmonary veins are actually going to deliver oxygenated blood that just left the lungs, to this left atria. And so we'll have pulmonary arteries that head towards the lungs, and then pulmonary veins which deliver blood to the heart. The ventricles are going to be the chambers that blood will be ejected from, and so these also will have great vessels in order to transport that blood from the heart to wherever it is going. So on the right side, the right ventricle is going to eject blood out, venous blood from that right ventricle through what's called the pulmonary trunk. And this is how deoxygenated blood or venous blood gets delivered to the lungs. Then on the left side, the left ventricle is going to generate pressure and eject blood out of what's called the aorta. And so the aorta will then deliver oxygenated arterial blood out to the rest of the body, out to the systemic circulation. The heart is going to have different valves to make sure that blood isn't going in the reverse direction. So on the right side of the heart, we're going to have what's called the tricuspid valve, and that is actually going to separate the right atrium from the right ventricle. And a good reason why we want that is because when blood goes from that right atrium to that right ventricle, Well, the next step is to deliver it to the lungs. So we wouldn't want any of that blood going backwards towards the atrium because we want to, get rid of as much as we can and send it to the lungs so it could get oxygenated. And then on the right side, we also have what's called the pulmonary semilunar valve, which is going to be located at the start of that pulmonary trunk. And, it's just going to open and close depending on what cycle of the heart it is. So blood can be delivered to the lungs and then, so limit the amount that comes or that would enter the right ventricle again. On the left side of the heart, we have what's called the bicuspid atrioventricular valve. That's going to separate the left atrium from the left ventricle. And then similar, we have what's called the aortic valve, which is located at the beginning of the aorta. And again, will open and close depending on what cycle or what stage of the cardiac cycle we're in. Here we could look a little bit deeper into what valves do. So each of them are going to have papillary muscles which help open and close the valves. And so let's say we're on the left side of the heart here, we have the bicuspid valve. When it's time to fill up the left ventricle, these papillary muscles will relax and blood flow will head down into the ventricle, due to gravity here. And so that blood flow is then going to start to fill up in the left ventricle. And then once it's time for this left ventricle to eject out blood, these papillary muscles will contract. That valve is closed, and that's going to prohibit any blood from going back into the left atrium once this contraction takes place. And then we could also see that, again, these valves, they prohibit any backflow. So when we have this valve closed, as we can see here in the pulmonary valve, it is going to prevent that backwards flow of blood. All right, so let's talk about blood flow in and out of the heart. So let's start with all of the venous blood, deoxygenated blood, entering the right atrium through the superior vena cava, which collects venous blood from the top of the body, and then the inferior vena cava, which collects blood through the bottom of the body. And so all that blood's going to enter this right atrium. And then what's going to happen is that this tricuspid valve is going to open. That blood is going to fill up the right ventricle, and then the atria will contract a little bit just to make sure that it ejects as much blood as possible into the right ventricle. And then this right ventricle is going to eject out blood. And how does it do that? Well, these muscle fibers, these cardiac muscle fibers, are going to generate force, and then that pressure is going to build up on the inside, and it's going to eject it out of this pulmonary trunk. And then once it enters the pulmonary trunk, it makes its way through pulmonary arteries to the lungs. Here is where some CO2 is going to get dumped off and some oxygen will be picked up by the red blood cells. And now you get this red arterial blood that's going to be transported back to the left atrium or back to the heart through the pulmonary veins and enters the left atrium. So once this left side starts to fill up in the atria, then the bicuspid valve will open, and that oxygenated blood will start to enter that left ventricle. This valve here will close, and then again, these muscle fibers are going to contract and generate force, and that builds up pressure on the inside of the ventricle. And when enough pressure builds up on the inside, the blood will be ejected, and it will start to enter the aorta and then be delivered out to the rest of the body, where then cells can pick up the oxygen, pick up the hormones, pick up the nutrients that are needed, and get rid of CO2 and different waste products. We talked about cardiac muscle in previous videos, but here we're going to really see the key differences between cardiac muscle and skeletal muscle or smooth muscle. So the important thing about the heart is that it acts together. All these cells are going to contract together. And so when it says these interconnected cells act as a functional synctium, that's what it means. They're going to depolarize and contract together. And what we're going to see is how that works is the left and right atria are going to fill up with blood at similar times, and then they're going to contract together, or those fibers surrounding the left and right atria will contract together. And then that's going to start to fill up blood in the left and right ventricles. And then once they're filled, the cardiac muscles surrounding both of those ventricles are going to contract at the same time and eject out blood. So you see top half fills, top half ejects, bottom half fills, bottom half ejects. And so, this depolarization, this action potential, happens together with cardiac muscle surrounding the atria and the cardiac muscle surrounding the ventricles. And we're going to see that cardiac muscle does have similarities between skeletal muscle, the important one is that basically the EC coupling process is very, very similar between cardiac muscle and skeletal muscle. And then just like smooth muscle, it has a rhythm, right? And so that rhythm is going to be generated by what's called nodal cells in the heart. And so cardiac muscle, they're responsible for generating force and ejecting out blood from chamber to chamber or out of the heart. And then these nodal cells, they're going to be responsible for setting the pace of those depolarizations and of those contractions. Here we could see cardiac muscle tissue, again, looks very similar to skeletal muscle. It is striated, and so we're going to have these sarcomeres, very similar to skeletal muscle. They're going to contain myosin and actin. The cardiac muscle tissue, their fibers, those cardiac fibers, are very aerobic. You got to think about it. The heart has to beat again every single second from the day you were born to the day you die. And so it needs to have this high aerobance, and so the aerobic capability. And so there's a lot of mitochondria in these cardiac muscle tissues. And then here you see the structure again similar to the skeletal muscles. You're going to have the sarcoplasmic reticulum, which is going to be responsible for ejecting out that calcium and causing the contraction of these sarcomeres, and then these transverse tubules, which that excitation is going to travel down in order to generate that contraction. So the heart is going to generate its own conduction system, and so what we have is basically a pacemaker of the heart that sets the tone for action potentials and then therefore for contractions. And this happens through a type of cell called a nodal cell. And so what's going to happen is that an action potential is going to be generated at what's called the SA node, and that's going to travel down a pathway that we'll highlight here in a second. And that electrical activity goes from that SA node out to the rest of the heart, and it just creates a uniform contraction every single beat. So the action potential is generated, like we just said, at this SA node. And that electrical signal is going to be sent through the left side of the heart, and it's going to jump from the SA node to what is called the AV node. And so once that occurs, we're going to see here that you are going to get that atrial depolarization in the fibers that are in the right atrium and the left atrium. And so once that message jumps, those cardiac fibers surrounding the atrium, they'll contract, and what that's going to help do is eject blood from the atria to the ventricles. And then this action potential travels from the AV node to the atrioventricular bundle, or the bundle of His as it's called, then down these left and right bundle branches, and makes its way down and up the heart through these little pathways called Purkinje fibers. And what that ensures is that every single one of these cardiac fibers are getting excited. And so once this message travels down and around those ventricles, or the cardiac muscle fibers that surround the ventricles, they're going to depolarize, generate force, and then that's going to help blood get ejected from the left and right ventricles. So again, SA node, AV bundle, left and right bundle branches, and then through Purkinje fibers. And that's how the heart is able to generate this action potential and contract all these fibers at once. Again, we call the SA node the pacemaker of the heart because it's going to basically determine how many times per minute the heart will beat. And so when it's producing action potentials more quickly, then the heart rate will go up. And if it's producing action potentials less quickly, then heart rate goes down. And you may have heard of pacemakers because some people, they have problems with conducting that current throughout the heart. So they need to have these pacemakers put in place in order to help generate those clean action potentials. Here we can see the action potentials that occur within nodal cells. The pacemaker potential is going to be what sets basically the rhythm of the heart. Longer pacemaker potentials means that there's going to be less beats per minute. And then shorter pacemaker potentials mean that there's going to be more beats per minute because each action potential is going to happen quicker. And so during that pacemaker potential, we have during the first half, potassium channels closed, sodium channels, voltage-gated sodium channels open, and then during the second half, T-type voltage-gated calcium channels also open. And then once we reach threshold in that nodal cell, L-type voltage-gated calcium channels are going to open. We get that depolarization of these nodal cells, and then followed by a repolarization. But that electrical potential here, going up, that depolarization, once that SA node gets depolarized, right? Once it reaches threshold and becomes depolarized, well, now we've started that all or nothing sort of principle. That action potential is going to jump from the SA node to the AV node and down all of these cells throughout the cardiac muscle. Again, the cardiac muscle fibers are going to be responsible for producing force and then building up enough pressure inside of these chambers in order to eject blood. And they rely on these nodal cells, on the SA node, on the AV node, in order for that electrical conduction to carry to those cardiac muscle fibers and then for them to contract. So they're not going to contract until they receive that signaling from these nodal cells. And we're going to see that those cardiac muscle fibers, they're going to have a very similar EC coupling process to skeletal muscles. We can see that the action potentials of contractile cardiac muscle fibers are different than the nodal cells. You're going to see a rapid depolarization when voltage-gated sodium channels open, and then the repolarization phase is a little bit more dragged out. You have that initial phase where sodium channels close and potassium channels open, but then these DHPRs, those L-type voltage-gated calcium channels are open. And since calcium's entering the cell while potassium is leaving, this extends out that repolarization phase, and that calcium is going to be important for the contraction within those fibers. But then once the fibers relax, you're going to see those calcium channels are closed, and then the potassium channels being open will take the cardiac muscle fiber back down to its resting membrane potential. Here's another look at it and what the EC coupling process is going to be in these cardiac muscle fibers. And so in a cardiac muscle, it's going to receive an action potential from a neighboring cell. And, in the skeletal muscle cell, it was a alpha motor neuron helping to generate this muscle action potential. Here, it's just going to be that, continuation of an action potential that stemmed from the nodal cells. And so neighboring cells are going to, have that action potential be carried along because of these opening sodium-gated channels on the sarcolemma, and that will travel down through the T-tubules of these cardiac muscle fibers. Similar to skeletal muscle, we're going to have an activation and an opening of what's called L-type voltage-gated channels, aka DHPR, and that's going to allow for calcium to come into that cardiac muscle fiber. That calcium will then bind to RYR. In cardiac muscle, it's called RYR2. That's the cardiac isoform of this receptor. But, it does the same job. And what it's going to do is when it's activated and it opens, it releases calcium from the sarcoplasmic reticulum out into the sarcoplasm. And then that calcium binds to troponin, just as it did in skeletal muscle. Tropomyosin shifts, reveals actin binding sites, and then myosin hydrolyzes ATP in order for those fibers to contract, to generate force, and eventually to eject blood, right? And so once those fibers relax, then the heart or the chamber is going to fill back up and the cycle begins again. So again, just pointing out the whole process. That's a little bit more abbreviated than I did for skeletal muscle. But the process is basically the same. The only differences really are that, again, the action potential is going to come from a neighboring cell in cardiac muscle, and that these two receptors, DHPR and RYR, are not physically coupled. So in order for cardiac muscle to generate force and create a contraction, it's going to rely on what's called this calcium-induced calcium release, where extracellular calcium binds to RYR2, and that allows this receptor to open and calcium to leave the sarcoplasmic reticulum and enter this cardiac muscle fiber's sarcoplasm. In the heart, we want strong contractions of our ventricles in order to eject out a lot of blood. And so, again, you see in these cardiac muscle fibers that we have this refractory period that basically lengthens repolarization. And what that prohibits is from another action potential from coming along and then creating another short, rapid contraction from taking place. We want those, heart chambers to fill up and then one strong contraction. And so if you didn't have this refractory period, what you could have is multiple action potentials creating these rapid contractions of the heart. And then that's not an efficient way for it to deliver blood. And these short, rapid contractions are referred to as arrhythmias. And, is the case of atrial fibrillation, you don't get good, strong contractions. So again, this refractory period, it's a mechanism to ensure that we generate a lot of tension out of these cardiac muscle fibers and that a good amount of blood is ejected from the ventricles or the different chambers of the heart. We are able to track the conduction of the heart through what's called an electrocardiogram or an ECG. Depending on how old you are, you may have also heard to this referred as an EKG, but same thing. We just call them ECGs now. So it records the electrical signal of the heart using leads, and we're going to break down each of the waves of the electrocardiogram and what is taking place within the heart during normal function, right? And so a lot of times these ECGs are then used to see if anything wrong is happening within that, conduction of the heart. And so we can point to certain pathologies and certain diseases using these electrocardiograms. The first phase of conduction in the heart is called the P wave, and this is when those action potentials that are generated in the nodal cells are going to travel across to these cardiac muscle fibers surrounding the atria. And so these cells are going to depolarize, and that is shown here by that P wave. So that PR interval, again, we're going to have that message jump from SA to AV node during that P wave is when the atria are depolarizing, and then they're going to be contracting right after. And then we are going to make our way to what's called the QRS complex. And so during this phase, the communication, the electrical conduction, jumps from that AV node down to around the cardiac muscle fibers surrounding the ventricles. So those fibers during the QRS complex are depolarizing. But what we also see that is masked by this huge wave right here is the repolarization of the atria. And so while the ventricles are depolarizing during this QRS complex, what is masked is the atrial repolarization. So again, the QRS complex, we're going to see the start of that ventricular depolarization, and that's going to start the contraction of that left ventricle. And so the force will be generated and pressure is going to build up within the ventricle, and blood will eventually be ejected out when the pressure inside of the ventricle exceeds the pressure on the outside of the valve, outside of either the pulmonary trunk or the aorta. And then what we finally have is once the ventricle ejects blood, well, we have to relax those cardiac muscles again and then get prepared for ventricular filling again. So this T wave is when that repolarization is going to occur, and then we will get relaxation of the cardiac muscles surrounding the ventricles. And so that's the whole process. We have, depolarization of the atria. Those cardiac muscle fibers will contract, then depolarization of the ventricles, those fibers will contract, and then the ventricle relaxes to begin again. And so You know, you've seen this probably in TV, movies, or if you've gone to a hospital, or if you had an ECG done on you. And this is just the rhythm of your heart. The heart is going to have specific phases, and during some of these phases, there will be a transfer of blood from one chamber to the next, or in and out of the heart. And then certain phases, blood doesn't move at all, and force is just being generated. So let's go through each phase of the cardiac cycle. The first phase is called passive ventricular filling. So this is when the bicuspid and the tricuspid valves on the left and right side here are going to open, and that's going to allow gravity to pull down this blood from the atria to the ventricles. And then just to make sure that we get as much blood as we can out of those atria, the cardiac muscle fibers will contract surrounding them. So once that communication jumps from the SA node to the AV and across, that's when we get that atrial contraction, and then blood will again continue to fill up in the ventricles. Once the ventricles are filled up with blood, we're going to get a closure of the tricuspid and the bicuspid valve, and then these valves are also closed in the pulmonary trunk and in the aorta. So what we get is isovolumetric ventricular contraction. And so again, isovolumetric because no blood is being transported from one chamber to another or from a chamber to a vessel. Pressure is just being generated inside because these ventricular cardiac muscle fibers are starting to contract. And that's going to help build up pressure on this inside. And then once the pressure on the inside exceeds the pressure on the outside, that's when we get an ejection of blood. The pulmonary valve here is going to open, the aortic valve is going to open, and that blood is going to be ejected from the ventricles out to the body. And so then once that occurs and all that blood's ejected, well, then we get a closure of these valves in the great vessels, and that's what's going to be called isovolumetric relaxation, because again, no blood is being transported from one chamber to the other, and then these cardiac muscle fibers surrounding the ventricles are going to relax, starting the cycle all over again. I think it's important to go back and make sure you are understanding how the electrical activity of the heart is tying in with the cardiac cycle. So all of this electrical activity, the depolarization, is going to lead to contraction. And this contraction period is known in the heart as systole. And so when you get systolic blood pressure, that comes from the blood pressure inside your vessels when your heart is contracting. And in particular, it's when your ventricles are contracting. So when you see systole, that means contraction. And so we have periods of ventricular contraction or systole, and then we have periods of ventricular relaxation or diastole. And so this electrical activity, again, it ties into the contraction cycle, where the atria or the ventricles are in systole or diastole, and that is going to tie in with the movement of blood and what phase of the cardiac cycle we are in. When you put on a pair of stethoscopes and you listen to the heart, you're going to hear two beats. You're going to hear a first sound, which is called lub, and a second sound called dub. And those are going to tell you when the different valves of the heart are closing. So that first lub sound is caused by the vibrations associated with the atrioventricular valves, the ones that separate the atria from the ventricles. So those are going to close during that first lub sound. And the dub sound is caused by the closure of the aortic valve, and therefore the pulmonary valve as well. And so first lub, those atrial ventricular valves are closed. Dub, then the great vessel valves are closed. We are able to measure the work of the heart, the efficiency of the heart, by a variable called cardiac output. And that's going to be the amount of blood that the heart ejects per minute. And so if you wanted to calculate how much blood is ejected per minute, well, you would want to know how much is being ejected per beat, and that is referred to as stroke volume. And then you want to know how many times a minute that beat or that contraction is taking place, and that's dictated by heart rate, which is going to come from the amount of times this SA node, this pacemaker cells are contracting or making a action potentials. And so when you multiply stroke volume, how much blood is ejected, times how many times it is ejecting, that's when you get cardiac output. So since stroke volume is going to be an amount of blood, typically measured in milliliters or liters, and heart rate is going to be a rate per minute, cardiac output is going to be the milliliters or liters of blood ejected every single minute. Stroke volume is going to be determined by the amount of blood inside of the ventricles and outside of the ventricles. The amount of blood inside of the ventricles, or the amount of blood that returns back to the heart and thus fills the ventricles, is called preload. And the reason why preload increases stroke volume is because cardiac muscle fibers, similar to skeletal muscle fibers, experience a length-tension relationship. So at normal rest, you could see that the ventricle fills up with blood. These cardiac muscle fibers will be stretched out to a little bit longer lengths, and that forces those fibers to create more tension and thus then create a certain stroke volume. But during exercise, we typically see that more blood is returned back to the heart, and we're going to talk about why that is in future lectures. But the muscles of our body are going to help generate pressure and generate venous blood back into our right atrium. And because there is more preload, because more blood is coming back into the heart, well, then more blood is going to enter the ventricles. In a higher preload or a higher end diastolic volume, or the volume of blood in the ventricles at the end of diastole, is then going to, make a more optimal length and create more tension in those cardiac muscle fibers. So the more blood, the more preload we are able to deliver back to the heart and fill up those ventricles, the more then blood is ejected, the higher stroke volume. You see that the cardiac muscle fibers have that similar relationship, and that they can be stretched too far, and then there's less cross bridges that can be formed. But the pericardium helps us and prevents us from getting from this descending portion of the length tension curve. So we're only going to hit these optimal lengths when we have a lot of preload, returning back to the heart. So main story here: preload increases stroke volume. So an increase in preload would equal an increase in stroke volume, and then a decrease in preload would actually cause a decrease in stroke volume. Preload's going to increase the force produced by these cardiac muscle fibers and then increase the pressure that will help eject out the blood. Afterload does the opposite. And what afterload is the pressure in these great vessels. So in case we're talking about the left side, that's going to be the pressure of arterial blood. And so when we talk about high blood pressure, this is what we're talking about, the amount of pressure in the arterial vessels and in this aorta. And so why that's so important is because, remember, liquids and gases travel from places of high pressure to low pressure. And so we're trying to get blood out of this left ventricle to the rest of the body, to the arterial circulation. And so if pressure is building up or is high in the arterial circulation and in this aorta, that means this valve, this aortic valve, is going to stay closed for longer, and the heart is going to need to generate more pressure in order to eject blood out. And so the more afterload, or the more arterial pressure we have, it will decrease our stroke volume. But the opposite's also true. The less arterial blood pressure we have, then less afterload and therefore higher stroke volume. Preload and afterload are volume dependent, meaning that preload depends on the amount of blood that's filling up the ventricles, and afterload's dependent upon the amount of blood that's in the arterial circulation. So those are both volume dependent variables that impact stroke volume. But we also have what's called inotropic agents, which can either increase the amount of contractility of cardiac muscle fibers or decrease the amount of contractility from cardiac muscle fibers. And so these come in the form of drugs or, different ions that can just influence the amount of force that cardiac muscle fibers can produce. It's got nothing to do with the amount of blood inside or outside of the ventricle. And so positive inotropic agents will increase the amount of force produced by a cardiac muscle fiber, while a negative inotropic agent will decrease the amount of contractility or the amount of force produced by cardiac muscle fibers. And so if you think about examples of this, caffeine is an inotropic agent, and so it's going to help lead to a higher amount of force produced by cardiac muscle fibers. And something like a beta blocker may be a negative inotropic agent and limit the amount of stroke volume produced by the heart. So how do positive inotropic agents work, and how do they produce more force in cardiac muscle fibers? Well, a inotropic agent can typically lead to something like norepinephrine binding to a adrenergic receptor. In this case, since we're talking about the heart, it's going to be a beta-1 receptor located on those ventricles. And so, this binding here will activate a G protein coupled receptor in that pathway to eventually lead to the activation of a protein called protein kinase A, or PKA, which is activated by the cyclic AMP that is produced by adenylyl cyclase. But anyway, protein kinase A, or PKA, can phosphorylate L-type voltage-gated channels, which allow for more calcium to come in to the sarcoplasm, and that calcium can activate RYR2. Protein kinase A can also activate RYR2 by phosphorylating it, and that's going to lead to it opening and releasing more calcium, which then can bind to more troponin and create more cross bridges within that fiber. And it also can phosphorylate SERCA. And the reason why that is, something that's able to increase the amount of force that cardiac muscle fibers can produce is because that, remember, in order to get this contraction to occur between myosin and actin, this cross bridge to form, we need calcium to be released. And in order for high amounts of calcium to be released, well, you need to fill up that sarcoplasmic reticulum back up with calcium. And so not only is the release of calcium from the SR important, but it's also important to then replenish those calcium stores within the SR. And PKA can do that by phosphorylating this SERCA receptor, the SERCA pump, and then that is going to create strong contractions within that cardiac muscle fiber. So many times these positive inotropes are going to manipulate one of the receptors within this EC coupling process, and that's going to lead to either more calcium being released or more cross bridges that are formed during the contraction. Again, the heart makes its own rhythm through these pacemaker cells. The SA node is going to determine the amount of action potentials generated per minute. But these nodal cells can be influenced by our nervous system through autonomic regulation. And so how that works is basically when we need heart rate to increase, like let's say when we're working out, there's going to be an increase in sympathetic nervous activity, and that message going to travel down sympathetic nerves. And the sympathetic side of the nervous system can increase our heart rate by releasing norepinephrine at the SA node. It can increase conductivity by releasing norepinephrine at the AV node. And it could also increase stroke volume by releasing norepinephrine, and that binds to beta-1 receptors on the cardiac muscle cells on the myocardium. And so here we see sympathetic nervous activity influences heart rate and stroke volume. But the parasympathetic side, the parasympathetic neurons just synapse at the SA and the AV node. So when vagus nerves here will secrete more acetylcholine, those bind to cholinergic receptors that can slow down heart rate and conductivity, but we can see there's not a parasympathetic nerve which synapses with the myocardium. So if you just want lesser or decreased stroke volumes, you would just decrease the activity of these sympathetic neurons that are synapsing here. How does sympathetic nervous activity influence heart rate? Well, what's going to happen is when norepinephrine binds to those receptors located on the SA node, it again starts this adenylyl cyclase G protein supported pathway, which creates cyclic AMP, that will open sodium channels, and this creates for a fast depolarization. So we're seeing here that, the pacemaker potential is shorter and shorter once you're having this occur within those cells, and that's going to create an increased rate of action potentials. And so instead of 2 beats as shown, normally, well, once you get those norepinephrine binding to receptors and this pathway occurring, that's going to increase the amount of beats per minute. The parasympathetic nervous system is actually going to slow down the rate of spontaneous depolarization. And you see that this pacemaker potential is dragged out, and that's going to create less heartbeats every single minute. And so within the cell, how that's occurring is acetylcholine is binding to its receptor, and then we get an opening of potassium channels, which hyperpolarizes the cell membrane. So as this as this SA node is trying to depolarize, we're getting a signal that is lengthening the amount of time that it takes to reach threshold. And so since now that rate of depolarization has decreased, then that creates slower heartbeats, and that's going to occur when you're at rest because there's no need for the heart to beat so fast, and so parasympathetic nervous activity is dominating. As we could see, our cardiac output can be impacted by many different factors, and so we know that the nervous system can impact both stroke volume and heart rate. So either the sympathetic branch will increase heart rate and stroke volume by releasing norepinephrine, and those norepinephrine binding to beta receptors on the heart, or the parasympathetic nervous system can influence just heart rate by slowing it down. We know that certain hormones, like epinephrine, can influence both heart rate then and stroke volume. The amount of blood within our hearts and our arterial circulation can impact both preload. So again, the more blood we're getting to fill the ventricles, the more stroke volume that will be ejected. And the more arterial blood pressure that we have, then the less stroke volume that is ejected. And then also just characteristics like age, gender, your physical fitness, your body temperature are all going to influence the production of your heart. Many people want to improve their heart health because a healthy heart means that our cardiovascular system is going to operate efficiently. And so aerobic activity is going to help improve the strength of those cardiac muscle fibers. And so aerobic exercise is anything that works large muscle groups for 20 minutes or more. And then once you get multiple training bouts, weeks over weeks, what you're going to get is adaptations that occur. And one of those is hypertrophy of the heart. So those cardiac muscle fibers, just like skeletal muscle fibers, can get bigger. You could, make more cross-sectional area, and those fibers then become stronger. And so just like resistance training is a stress that signals growth within our skeletal muscle cells, endurance training, aerobic training will do the same for our cardiac muscles, and it's going to create stronger hearts, and what that leads to is higher stroke volumes, right? So stronger cardiac muscle fibers going to lead to more blood being ejected from the heart. And then when you think about it, at rest, if your heart is able to eject out more blood, well, it doesn't need to beat as many times per minute, which is why athletes and people who are in shape have low heart rates, known as bradycardia. And so you're going to see that someone who's trained can have very, very low heart rates, very low beats per minute, because again, their cardiac muscles are strong enough and produce enough stroke volume in order to supply enough oxygen and enough blood flow to the rest of the body without having to beat 70 times per minute, 80 times per minute. That will conclude this lecture on the heart. And so what I want you guys to go back and really focus on is the different chambers of the heart, the direction of blood flow, the steps of the ECG, the steps of the cardiac cycle, the things that increase stroke volume and decrease stroke volume, the things that influence heart rate, and then therefore the things that influence cardiac output. We are going to continue our conversation on the cardiorespiratory system by talking about the blood vessels in the next chapter, and then we'll discuss the blood and the components of blood, and then we'll talk about how we get oxygen and CO2 in and out of the system to, trade those blood gases back and forth between the body and the lungs, and then how we ultimately, get air in and get air out of this pulmonary system. Thank you guys so much, and I'll see you next video.